So always remember this. This happens every time in MS trials. And this has nothing to do with you as MS patients. Every disease, or most other diseases of a similar nature that are autoimmune, have inflammatory component, things swing back and forth. And like Dr. Knox was saying, you can have a day-to-day variation. You all know good days and bad days, good weeks and bad weeks. There's also good months and bad months. And therefore, when you get a population of patients for a study who is hot, in other words, is having relapses, it's only quite normal for them to regress to the mean, as in they will all seemingly get a little better. So there's the placebo effect. And the other thing I want to impress upon you is that this is not to say this means this is all in your head. That's not placebo. Placebo effect has a number of reasons. It's well known. This is not the only study. Every study has a placebo effect, and that ranges from 30 to 70%. In this one, happened to be 60%. And that's why, compared to this, you have to see what did the drug do. And that's why, if we ever get to any other therapies, be it CCSVI, other drugs, and so on, control arm has to be there. So proper numbers, proper randomization, and the control arm. This graph shows you over a 2-year period, did the patients progress? Of course they did. But patients who took the fingolimod, low and high dose, progressed at a much lower rate than the placebo group. How low? So there are the numbers. So basically it is statistically significant. There was a 30% reduction in accumulation of disability over time, over that 2-year period of time. So that's the FREEDOM study, and that was pivotal in getting this drug to the market. But these days, regulatory authorities are looking for something else. They're looking for head-to-head trials. They're saying, yes, it's a pill, it works better, but show us that it works better. And you cannot look at this and say, well, our study showed a 56 to 60% reduction of relapses. That's better than the 30% shown by interferons. Ergo, our drug's better. No, you can't say that. Because interferon studies were done 15 to 20 years ago on a different cadre of patients. So you cannot say that unless you do head-to-head trials. And so TRANSFORM study was a head-to-head trial. Let me explain what was done in this one. So again, about 12 to 1,300 patients were randomized to receive low-dose fingolimod, high-dose fingolimod, and one of the existing therapies, which is interferon given intramuscularly weekly, or Avonex. This was a 1-year trial. They had an MRI scan at the beginning, MRI scan at the end, and they had a number of clinical assessments in between. So at the end of that 1 year, the patients who received interferon had a relapse rate about 0.33, but compared to interferon, not placebo, the fingolimod patients had relapse rates of 0.16 and 0.20, not too much difference between the two doses, but certainly better than the Avonex group. So certainly 52 to 38% reduction compared to an active arm. So yes, they can go to the regulatory agency and say, we are better. And we can say, we are better than this one interferon. You have to be in the world of scientific evidence or medicine. We can only say things as what you studied. So you can say it's better than this particular interferon. I don't think you can extrapolate it and say it's better than all 4 other drugs. Can't say that. So the summary is that this drug has good efficacy on MRI, on relapses, on disability progression, and it seems to be better than one of the agents like Avonex in a head-to-head trial. It seems like the lower dose, the 0.5 milligram, had as much efficacy as the higher dose and had less side effects, was better tolerated, so that's why that is going to be the going forward dose. There were some concerns. There were some issues with skin cancer, opportunistic infections, as in infections from bugs that normally don't attack people with normal immune system, and some fluid accumulation in the back of the eye, which also, anytime anything happens with the eyes, it's very serious and alarming. But these were signals, safety signals, not something that came out as obviously there. So last month, FDA approved this drug, but they said, number one, This drug, the first dose has to be given in a clinic setting so that there's proper monitoring for the heart. Number two, an eye doctor has to see the patient before and after starting the drug in 3 months' time because of this fluid accumulation in the back of the eye called macular edema. And that they also wondered if 0.5 is the appropriate dose, perhaps even 0.25, half of 0.5 might do the same trick. So they're asking the company to do another study with a lower dose because in the end, the role of the regulatory agencies is to give out or give approval to an agent in the safest possible dose possible. We're waiting for Health Canada, so in the next 6 months to a year, we'll know whether they want to approve it in Canada or not. So that's fingolimod. I spent a little extra time in that because I wanted to emphasize to you, A, it takes roughly about 10 years from an idea to regulatory approval. What are phase 1, 2, and 3 studies? How big should the phase 3 study be and why? Because you need proper numbers, proper randomization, and always a control or placebo arm. Let's get on to the next drug, cladribine. So this is another oral drug, a pill, that in the IV form has been around for a long time. It's in fact used in a very rare form of leukemia called hairy cell leukemia. It's a cytotoxic drug, which means it kills the lymphocytes, and that's why when you take this drug for a few weeks, its effect remains there for a couple of years. So this is an oral agent that you don't need to take on a regular basis, so that's the good news. Bad news is that your lymphocytes are depleted and depleted permanently for a year or two, and what are the risks and so on. Its effect, and then there's a phase 3 trial called Clarity trial that was done and showed efficacy. So here's the phase 3 trial. On MRI scan, you can see a very robust effect, anywhere from 74 to 85% reduction in new lesion formation on MRI scan. On the relapses, there was a 57 to 55% reduction with both doses of cladribine compared to placebo. And again, I hope I have that arm. Yes, I do. So you can see these patients started off with 1.35. So the bar actually couldn't go high enough on this slide for me because it would be way up there. So the placebo reduction was impressive with this trial. They went from 1.35 to 0.33. This is almost a 70% or 75% reduction in. Okay, that's the power of control and placebo arm. But it's compared to that the cladribine had the effect. And this is what we're looking for, not what happened from baseline. And on disability progression, again, roughly about 31 to 33% less progression. But you notice that you still see some progression. This is what bothers us, is that we're not yet anywhere near an agent that would make this into a flat line. That's what we would like. We would like to have an agent that is safe enough on day one after diagnosis, say to the patient, take this and your MS will never change again. We're not there. So in summary, from Clarity, it seems like an effective agent. It's well tolerated. 90% of the patients took this drug for those 2 years. And long term, though, for all of these agents, the safety is still an issue. Why is that? Because a 2, 3, or a 4-year trial is not good enough to tell you about safety things that can come, as you know, in full what we call post-marketing surveillance. These things can be dug up 5 to 10 years later, so safety remains an issue. There's a large cladribine program. I told you about the Clarity study. Now those patients are being followed in an extension study. There's another study called Onward study where this drug is compared to Rebif or added on to Rebif. There's an Oracle study which studies 640 patients with clinically isolated syndrome. So patients with first attack are given this to see what happens there. There was a bit of a setback. I've showed you very impressive data, but here again, we have to trust our regulatory agencies. And the European Regulatory Agency did not think that the safety issues are totally dealt with, and therefore ruled against cladribine. Now currently, there's a negotiation back and forth. The regulatory agencies may want some extra studies to be done or some other safety standards to be adopted. But the bottom line is, don't think that after all of this work that the regulatory authorities just stamp it and say approved every time. They don't. Here's the best example of that. We're still waiting for FDA and Health Canada. Their decision will be coming in the next 6 months to a year.